All right, so this next topic is going to be behavioral emergencies. We're kind of talking about care and transportation and some of those things along the lines with the psychiatric patients. So if you have experience with this, we'll kind of talk about your experiences and how you handle those and some of the safety considerations to be aware of. But obviously, one of the very first things we want to talk about is going to be the safety side of things. Tomorrow, I think it is, we're going to talk about, so it's Saturday. Saturday, we're going to talk about scene safety, and you'll get a chance to kind of hear my take on that. It's much, much different than most other instructors you probably heard the scene safety talk from, and we'll kind of talk through that. But safety obviously has been a huge piece of that. Want to make sure that we're not putting ourselves in circumstances that's going to get us hurt or get our partners hurt or things along those lines. The issue obviously on the dispatch side is going to be the fact that, you know, for the most part, dispatchers kind of get the short end of the stick. They really don't know what we're going into. So we kind of get on them and be like, hey, how come you sent me into that scene and that guy, wanted to fight and hurt me? Well, it's not like the phone call was made and said, I want an EMS provider so I can, pummel him to death. Usually what comes up, I don't feel good, I have chest pain, I have shortness of breath, I want to go to the hospital, something like that. But definitely on the initial assessment side of things, usually holding up to the scene, you have a pretty good idea of what you're going into or what you're going to encounter. So obviously a half-naked guy jumping in the middle of the road, you probably should just stop your ambulance, turn around, and request some law enforcement. But be thinking about what are you walking into, what does that house look like, what's the living conditions, what's the neighborhood you're in, things along those lines. And we'll kind of talk about all those pieces. So obviously the reasons for this psychiatric behavior or behavioral emergency obviously can range from stress or physical trauma or illness, drug or alcohol abuse, some sort of psychiatric condition. We obviously deal with that large population, schizophrenia, bipolar, depression, things along those lines. Depending on your area, your response area, you might have facilities there that are directed towards some of those populations. So you might deal with them on a semi-regular basis. The area where I work on the ambulance, we have a couple of like juvenile facilities for kids that are known to be psychiatrically unstable or violent. So those always kind of bring their own unique pieces into those every single time. So we'll kind of talk about some of those as we go through them. So obviously on the behavioral emergency side, what we're talking about as an emergency would be defined as when their actions become intolerable or unacceptable to the patient themselves, the family, or the community they live in. So kind of be aware of that piece of, we have a hard time transporting these people because they're not really a medical issue. So taking vitals and splinting and things like that, the skills that we're used to practicing aren't really used. So it's other skills that, we'll talk about verbal judo a little bit later and walking through those pieces. The one piece this presentation doesn't talk about that is kind of my new recommendation for all EMTs, especially the EMT student side, is dealing with autism and autistic kids. I really think that EMS lacks substantially in the training when it comes to dealing with those individuals. On the family side, on the care side, about every side there is. There is a program here in Spokane. It's called Autism in the Wild. And what it actually is the Isaac Foundation paired with the city fire department here. Isaac Foundation specializes in autism, and one of the city fire individuals here has an autistic son. They put together a program. The program has two sides. One of the sides is they actually take autistic kids out and get them exposed to the ambulances and the fire trucks and law enforcement, uniforms and people with authority and things like that, which really has helped that transition. But the other side is reaching out to EMS and be like, hey, how could we help you handle these kids? You can look it up online. I think it's on YouTube. I think it's an hour-long video that talks about some of the ways to handle those kids and communicate, how to work with families and so on. It's an awesome, awesome program. I'll bet you if you contacted the Isaac Foundation, you could even probably arrange to have them come out and do a presentation in your agency to talk with you and your coworkers about responding to autistic kids, just because they're trying to get that message out. I think the current rate for autism is 1 in 68 kids, I think is the statistic. I thought I had seen somewhere they had anticipated that to be 1 in 28 by 2024 or something like that. They anticipated that rate to go up. So we're going to probably see an increase in that population that we're going to be dealing with. So behavioral patients may appear confused or have altered mental status, or they can be violent, they could be not violent, they could be angry, they could be happy, they could be quiet, they could be really talkative, they kind of vary in their presentations. Common psychiatric conditions that we're kind of talking about are dealing with anxiety or panic disorders, depression, bipolar disorder, schizophrenia. Obviously, dealing with the homeless population, we deal with a lot of those bipolar, schizophrenic individuals who've been on their medications are somewhat easy to handle. The downfall when they're not on those medications that help them be normal functioning or semi-functional individuals, these presentations can go kind of opposite in the direction we're kind of going. On the differential diagnosis side, I always tell EMT students to be really, really careful. Don't assume that they have a psychiatric condition, right? Make sure you rule things out that mimic those psychiatric conditions: low glucose, low oxygen, hypothermia, head trauma, mind-altering substances, things along those lines. Just be aware that you throw some of these things up on your differential diagnosis list. It would really, really be a bummer if you took care of that schizophrenic patient who was violently restrained in a stretcher and you did nothing for it because they reported them dangerous, and you get to the hospital and find out their glucose is only 15, and you could have done something to correct that and help them out. So make sure you still do, if you can, obviously, still do the procedures that we do on all the calls, or use all the calls we're supposed to. Situational stress reactions, and Bryce is going to talk about this a little bit later today. When he comes in, that's into coming at 4 o'clock. We'll talk about kind of normal reactions to stressful circumstances that can produce emotions. If you're on the EMS side, you guys in the industrial setting probably not likely to deal with it, but notifying that family or being around that notification of, "My man, sorry, we tried everything we possibly could, but so-and-so has died," that reaction that family could have to range in presentation. So just really be aware of that one. Bryce is going to talk about a little bit today. I think that EMTs kind of get the short end of the stick, and we're basically told, well, you'll never have to be part of a death notification, so we shouldn't teach you how to do it. You get in those role settings, and you may not have started CPR, because that then falls on a different guideline. Maybe you showed up and there was a reason why you never even started CPR in the first place. Then you are directly related to that notification of that family being like, "Listen, here's why we're not starting CPR." There's no class. I'm sure in your EMT class you were not taught how to speak to somebody about their loved one being dead. So Bryce is going to talk about that and how to do so, and some tricks to that one when he gets here about 4 o'clock. So on the stress reaction side, and this kind of goes with dealing with all behavioral patients. A couple of things up there in red: don't rush in, so slow down, make a good assessment, pay attention to your environment, pay attention on Saturday. If we're short on time tomorrow, we'll move the scene safety presentation to tomorrow. But we're going to talk about your body position and your body posture and how you perceive yourself and how we handle ourselves and things along those lines. Like I said, I have a really different take on scene size up and scene survey than you learn in your textbook. Make sure you let the patient and family know you're there to help them. You should never be, and I don't mean like impersonating like on purpose, but you should never be perceived as a police officer. That's not going to help your case. That's not going to make this go easier. In almost all cases, this actually makes it get harder on you. So make sure that you perceive yourself as an EMS provider, which means I'm an EMT or advanced EMT, or I'm here to help you. I work on an ambulance and things along those lines. And make sure they really understand that you're there to help them, not hurt them. Because we're going to talk about reasonable force here with scene safety and what that looks like. Remain calm. Most of these circumstances already have enough stress and anger and reaction that you don't need to be doing the same thing. So keep your stress level down, keep your heart rate down if you can. If you start getting amped up, take some deep breaths, take some steps back, and kind of keep yourself as calm, cool, and collected as you possibly can. Keep your emotions under control. These definitely can be emotionally taxing and emotionally draining. So I know we all come to work, 12 hours of sleep before, and we're well fed, and we're not cranky. We don't have our own life problems already going on, and all those kinds of things. So try to keep that stuff under wraps and under control as best of your ability. This is the one that I feel like a lot of people tend to forget. When you ask a question, I always tell EMTs to shut your mouth and listen to the answer. Don't just fire questions at them as quick as you can, because a lot of times that's agitating them. The patients that I've had those physical altercations with, looking back, there's a handful that I probably contributed to that physical altercation, where you just poked and poked and poked and poked and poked, and they exploded, and you're like, whoa, 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 why did you punch me? Well, you've been beating them with questions for the last 25, 30 minutes, and they don't want you to take a blood pressure when you start this. I have to take a blood pressure. It's part of my job, and I have to do it. And they're just going to get mad. Most of these patients, you sit in the jump seat and transport to the hospital. You don't even have to take vitals, right? It just comes down to family doesn't have the means to transport them. Law enforcement doesn't want to transport them or can't transport them. So you're transporting them literally as if you were a taxi. So be aware of that, what you're capable of. The second to last one up there is obviously be honest. Don't lie to them. I'm point blank with these individuals and listen, I'm not here to hurt you. I'm not here to take you to jail. You remain nice and calm and remain nonviolent. We'll have a nice, easy, slow ride to the hospital. And we can talk. I usually give them the option, do you want me to ask you questions and talk to you? Or if that's going to agitate you, I'll just sit here in silence. And I'll just go back, sit on, on my computer, do a report or whatever the case might be. But ask them, what is it they want? What does it make them comfortable? What makes them uncomfortable? I think in this PowerPoint, if I took it out, it talks about personal space and being that 4 to 5 feet range. In my opinion, if you take steps towards them and they take steps back, you've now encountered their personal space. So don't keep getting into their personal space and wonder why they appear to be getting agitated and pissed off and things along those lines. Be alert for those changes in behavior. Again, patients don't suddenly deteriorate, you suddenly notice kind of thing. Really be aware of the fact that, your patient went from, real calm, cool, and collected. Now they're clenching their fists. You start to notice they're shuffling their steps to kind of be in that fighting stance. They're starting to raise their voice. They're starting to yell at you. They're taking steps towards you, which should be alarming. It's amazing when this goes sideways how many red flags we miss after the fact. We're getting debriefed and we're like, holy crap, there was like 9 red flags leading up to this that we probably could have, blew the whistle on and changed the outcome. Acute psychosis, that's going to be that severe break in your patient's ability to process information and interact with their environment. Usually this is associated with some sort of cognitive disorder, like something like schizophrenia or something along those lines. Sometimes it's the medication issues, sometimes it's just there's an event and it just causes that break or that change, and now those patients are reacting in the way that they're reacting. Symptoms, hallucinations, delusions, that catatonic state, that thought disorder, things along those lines. Again, your safety, like I said, we're going to really talk pretty hard on this, that your safety and things that you can do to protect yourself and things like that when you get into scene safety. Emergency care specifically, anybody have any experience with these? I mean, on a regular basis or semi-regular basis or once or twice, or what are your guys' thoughts? Like, what are some of the things that you do when it comes to care? Or what are your thoughts? Any tricks of the trade? Anything?
Be aware of what's going on around.
Be aware, right?
Somebody,
What's that?
or have somebody else keep an eye on them.
Okay. What else? Have an exit. Have an exit, right? It's not like plan B, which usually involves, oh shit. So be thinking about, like, what are we going to do when there is a plan B, right? Plan B is not, it's gone wrong. We're into plan C. What was our plan B, right? I always say plan for A, B, C, D, and E, because once you start getting to F, we all know that plan F is just going in. Things tend not to go so well when you get into plan F. But so have an exit, have to watch it. What else? These calls take a lot of time. They do, right? They're not emergencies in most circumstances, right? These aren't critical patients. I can't remember any time in my career my psychiatric patient has been unstable, right? Unless you're involving, you know, suicide attempts, then maybe you could argue. But for the most part, these patients are, you know, the typical tone out is, you know, MHP on scene, patient needs to be transported to the hospital. You show up and they are conscious and alert, they're breathing normally, their heart rate, like everything's perfectly fine. It's just you are the mode of transportation they're going to take to the hospital. So lots of time associated with that. Anybody here been assaulted? One shaking your head, only one? That's like myself. You want to talk about state like what went on?
Psychiatric break on canoe in the ambulance.
Really?
Yeah, he went from
Like canoe.
in canoe, yeah, from trying to kill me to jumping out. Saying he was going to commit suicide. And he would sink a little bit. Self-correct, and then I want to kill again.
So what was your exit plan? The canoe in the middle of the body of water, just get in the water?
No, I mean, so I protected myself in a protective stance. Yeah, outside of the canoe, and then somebody else come up, so the canoe went flip. He took over about 2/3 of it. I got a third of it. I kind of covered his space. And eventually he got evacuated by law enforcement.
Nice. Not nice.
Well, there's things with it.
I don't fight the back of the ambulance that canoe, I'm thinking. I used to think back of the ambulance is a real bad idea, but I think the canoe is the worst. Can't think of a worse place to fight somebody that did something. They take you over the water. Anybody else or just the one? So those are things to kind of think about. You guys will get assaulted in your job. Usually it's your
Just my manager.
yeah, just your paycheck. So we'll talk kind of about that body posture. The rate is becoming pretty high about EMS providers getting assaulted. So if you're still in EMS, it's probably a good chance that will probably happen sometime in your career. And we'll kind of talk about that when we get into the scene safety stuff. Key techniques: make sure you identify yourself and your role. I love the individuals that are, you know, screaming, yelling, "You're going to take me to jail! You're going to take me to jail!" And I very nicely remind them that I don't have a badge and a gun, nor the capable of taking them to jail. That's not my job, so that's not why I'm there. You know, keep your hands out of your pockets. You know, we're going to talk about body posture and position. Just be really careful. It's very easy to be in a good posture to protect yourself, but to also be perceived as somebody who wants to fight or in a fighting stance. So it's a fine line between, like, you know, protecting yourself and also not looking like you're looking for a fight. Speak slowly and clearly, make eye contact, unless that's the one thing that seems to be pissing them off the most, then don't make eye contact with them, right? So pick up on subtle cues that those patients are exhibiting to tell you, hey, you know what, I'm not having a good time, it's even fun for me. Keep our emotions under control. My biggest problem is when I get stressed and I get scared, my initial reaction is laughing. And that's not the best reaction in some of these circumstances. So I'm trying to keep your own emotions under control. Laughing at the psychiatric patient who says he's going to stab you, really not high on my priority list. I can't control it. But you laugh and cry and laugh and cry. Listen to the patient. Don't be judgmental. Use positive body language. You know, arms not crossed. You know, not leaning against the wall, those kinds of things. Act like you want to be there. Act like you are there to help them. I used to work with a person who we used to call it sitting on the box, and we had Pelican cases. And it used to drive me nuts. We'd go on a scene, he'd set the Pelican case down and sit on the Pelican case and ask all of his patients sitting like below the patient. And when I very first started my EMS career, I was like, that seems comfortable with an idea. And you learn about like one of the worst places to be when something goes wrong is sitting on a drug box, you know, a foot off the ground. You know, they can get the upper hand of you pretty quick, and you get people complain that it made it seem like you didn't care, you didn't want to be there, and you know, our response is, well, at 3 in the morning, you don't care, and I don't want to be there, but they shouldn't have that perception of you, right? Because we're in this job for a reason. Acknowledge patients' feelings. You know, be sympathetic for what they're feeling. You know, don't say things like, I understand what you're going through. Just be like, you know, I'm hearing what you're saying. I'm very sorry that you feel like that. You know, let's get you taken care of. Let's, you know, let's get you the help you need. You know, what is that? What is it you need? You know, what do you want from me? What do you want from your family? And be able to relay those things to the hospital. Suicide patients, maybe the one thing you need to hear is, you know what, man, it's not a good out. You know, people do care about you. You know, be thinking about that and try to use those pieces. And let's be good patient caregivers. Again, don't get in your patient's personal space. Again, they say that's 3 feet. 3 feet is really freaking close in my opinion. You know, me and Dan were kind of joking back and forth. There was no personal space. I sometimes don't have it. Sometimes I do. When I do have it, I'll tell you it's a hell of a lot bigger than 3 feet. So just kind of be aware, you know, 3 feet is often close to be to somebody who could really easily haul off and punch you in the face. 3 feet's often close to taking a punch. So kind of be aware of that and what that looks like. Be alert for changes in emotional status, and then restraint to prevent harm. Anybody here have any protocols that says you cannot restrain patients? No, every once in a while there's an agency that says you can't restrain without law enforcement. The downfall is sometimes law enforcement's not there. What you're supposed to do for the 19 minutes it takes them to get from Dunkin' Donuts to your seat. So, I should put that up for like that's one. We'll edit that out later. Oh my conference, sorry, conference. But be aware that, you know, use physical restraint. If you got to do it, then do it. What I always tell students is don't half-ass it. If you're going to go hands on someone, then go hands on somebody and win. The only fair fight is the one that you come out on top. So don't do the one hand. I'm kind of like, if you're going to go hands on somebody, then freaking jump both feet in, do it, get them restrained, and then start back. We're not here to hurt you. This is not where I wanted this to go. You know, sadly, you made the choice. Now we're here. You're going to stay restrained. Let's, you know, make sure they're on their side. They got a non-rebreather. They have a nasal can. Like, you know, help them on the medical side. I will talk about that more with the scene safety stuff. On the hallucination side, the EMT textbooks obviously say don't play along with patients' hallucinations. My opinion is if it's harmless, it gets them in the ambulance, maybe, but other than that, you know, don't say you see the same bugs or whatever. Just playing into delusions or hallucinations that don't actually exist. Now you're validating those, so now it's going to be even harder to convince, you know, but the paramedic said they saw the same ghost or whatever. You know, that's not really reassuring. So make sure that you, don't play along with those. If you ever seen this guy's name, Steve Barry is the guy who does these. I think his comic strip is called, I think it's either called like Not an Ambulance Driver or something like that. But he's got all these cartoon PMS, and I think they're funny. Basically, get a chuckle out of them. When it comes time for interactions, especially on the side of things of restraint, we're going to take a poll here in the classroom. How many of you agree that this probably is a picture of what not to do, even though this is the textbook's version of this is how this should go? I see about 19 problems with this entire scene.
The first problem is the black gloves.
Yeah, black gloves.
That's scary.
Yeah, that's scary. Second top, this carrot top looks like he's literally going to beat the hell out of all of them. Obviously, you know, you've got, what they're trying to say is you should have 4 rescuers to 1 patient. We do recommend that 5th rescuer for airway control if absolutely needed. I love this 5th rescuer, if available, can control the patient's head, taking special care. However, not to be driven. You don't want that. Then you go into a zombie and take you off the Walking Dead, and it's just a long process. It takes seasons and seasons to actually kill you. But those are the things to be aware of. Pay attention to people biting and spitting and kicking and punching and things along those lines. If you're going to have to go hands-on to patients, I know these little, I call them man purses, these little radio purses I know have become popular. I personally have one. That's not something you want wrapped around your neck when you start fighting this guy, because he's probably going to use it against you. I'm a big fan of having a radio on for calling out to law enforcement or calling out to the one person who actually cared, which is your dispatcher. But just be aware that keep it away from around your neck and things like that, so that way it's not used against you. I'm sure there's some conversation like, don't worry, we're here to help, we're not here to hurt you. But this looks like the most offensive posture possible. You got 4 guys, you're encircling your patient, you're going to have your hands on your patient. This kid looks like he probably could take all 4 of these other people. The other one I really don't like is if you haven't had any training or you haven't practiced this with any of your partners, I love the conversation that literally goes on right in front of your patient. Hey, on the count of 3, we're going to grab him. Everybody ready? 1, 2, 3. The whole time this guy's listening to this, like, all right, we'll bring it. So some sort of training or some sort of practice or communication prior to this call, I think it really makes this a little more successful and a little bit easier to handle and things along those lines. On the patient assessment side, nothing really goes here. This big thing is just making sure to remind ourselves about safety issues and in the different presentations and things along those lines. Perform a careful scene size up, identify yourself and again your role. Introduce your partners, introduce your team. You walk in the door, it's me and Josh. Don't just, hi, I'm Sean, I'm with Deer Park Ambulance, how's it going? Make sure you say, my name's Sean, this is my partner Josh, we both work for this agency, this is what we're here for. So that way they feel like you're not trying to hide somebody from them, who's just kind of standing in the back, who all of a sudden initiates patient care, and they're like, wait a second, I don't know you, and that can just tip this thing all over to one side. So kind of be aware of that. Complete your primary assessment. Again, airway, breathing, circulation. On the suicide side, just don't forget about trauma, self-inflicted knife wounds or self-inflicted gunshot wounds, or things along those lines. Make sure that you are still assessing for those. Gather that thorough history, get that detailed exam, get as much information as possible. Most EMTs are really great about, are you taking medications? The one we're really bad about, are you currently actually taking them, right? Are you prescribed them and are you taking them? Is a big difference between, I prescribe medication. Well, they haven't taken them in 2 or 3 days, then, we're dealing with a whole different issue here. Common signs and symptoms: panic, anxiety, unusual appearance, disordered clothing, poor hygiene, unusual speech patterns, suicidal or self-destructive behavior. My EMT class taught, patients who are suicidal have a high rate of homicidal as well. So just be aware that you think of your safety at all times. I'm not saying they're going to murder you. Just be aware that if they want to hurt themselves, it's just one easy step to cause damage to other people. Be alert for personal or scene safety problems. Treat any life-threatening problems. Encourage your patients to discuss their feelings and talk about those. Never play along with those hallucinations. What are your thoughts on that last bullet point? Consider involving family or friends. What do you think? Yeah, right. They could be your little secret weapon, and they also could be the fact that this whole thing spins out of control because of them. So use them, accordingly and carefully. Make sure you get a handle on the situation of this is getting out of control or something along those lines. On the suicide side, we're talking obviously our patients. We'll talk more about EMS suicide a little bit today, a little bit tomorrow. What we're talking about is the suicide patients. 8th leading cause of death is 3rd leading cause in the age group ranging from 15 to 24. So obviously a pretty broad group there. We are starting to see a rising number in the elderly population as well. The difference is the suicide means is usually more lethal and more life-ending in that geriatric population. They don't cut their wrists, they don't take pills, that kind of thing. Usually involves firearms or something along those lines. Where in this population here, that 15 to 24, we see all kinds of range of means of doing so, whether that's hanging or poisoning or cutting their wrists or eating Tide Pod, laundry detergent, or whatever else. All those things are possibilities. Explore the following possibilities. The history of depression, high stress levels, recent emotional trauma. Do they fall in those categories? That 15 to 25, 40 and plus basically tells you you're good from 0 to 14 and between 26 and 39. Outside of that, you pretty much fall in these two pretty large categories. I feel like that's not a very big time to be alive, but drug or alcohol abuse obviously contributes to that. I love, these are your high risk individuals. To me, that literally just sums up most of the population. Especially in EMS, obviously, we're starting to fall in these two big populations, high stress levels, and emotional trauma. Suicide in EMS is rapidly increasing. We've got to get a handle on this, whatever the problem is. We'll talk a little bit about this tomorrow, but starting to get a handle on what that looks like and so on. And so we got to start treating that kind of cut that off. Ask about threats of suicide. Do they have a suicide plan? Previous attempts or threats. Then a big red flag. I think this is kind of poorly placed in this PowerPoint, but the red flag is this sudden improvement from depression. So what happens is they're severely depressed, and when they decide they want to commit suicide, leading up to that, they don't want to give it away. They don't want someone to realize what they're going to do. So they all of a sudden just suddenly flip over to the opposite side and become the happiest person on the planet. You know, a lot of people are like, oh, well, hey, glad you got help, glad you got taken care of, you know, good to see you're doing better. And then, you know, a week and a half later, we hear they commit suicide, right? So be aware that's more of a big red flag on that side of things than it is like an actual positive thing. Interacting with them, this is going to be huge. Obviously, you know, I'm not a horribly touchy-feely person, but I will tell you on those suicide patients, you know, I get on their level, talk to them. Almost all of my attempted suicide patients, I have a conversation like, listen, you know what, I don't think it's worth it. You're going to hurt somebody. People are going to have to kind of, you know, deal with it after you're gone. You know, if you're looking for someone to care about you, you know, I don't want you to die. I don't want you to take your own life. You know, now I'm invested in, like, use those pieces and make them understand there's people that care about them. There's people that want to hear about them. There's help. There's people you can talk to. There's things that you can do. There's programs you can be in. There's outlets where you can ask about what do you like to do for fun, and you know, why don't you go do one of those things or something along those lines to use to kind of help them get better along this whole process. Aggressive and hostile patients, consider clues. You know, your dispatch information from family or bystanders. Again, that patient's stance or position in the room is going to be one of your giveaways, in my opinion, of these patients are getting better or getting worse. I'm a big, you know, I've worked with people, I've been around people who threaten patients. You know, listen, if you're going to keep this up, you know, you and I we're going to go toe to toe, and it's not going to go good for you. That's not a very good approach to trying to keep this less structures, adding fuel to a fire that, you know, and sadly when they go, when you're at a disadvantage, is they know when they're going to attack you, you get to react to them acting. So that's going to be a little bit slower, and obviously they can have some issues with that as well. Stay alert for weapons of any type. We're going to talk about tomorrow or Saturday. We're going to talk about weapons and how to deal with those and what to do when you encounter them. Because in your EMT class, I'm sure they all taught you, just like my EMT class, you know, just don't go into scenes that have weapons and they'll be safe at all times, right? Well, I work in Stevens County, so every house has at least 7. Most of our, you know, scenes you're going to go in probably have weapons. So the presence of the weapon does not deem your scene unsafe, right? It's not the presence of the weapon, it's the intention of the use of that weapon that becomes unsafe, right? You go on car wrecks, and we forget all the time. I transported a guy, it was a car wreck, he had 2 kids in his car, the kids were actually injured, and Dad was going because he didn't have a ride, yada, yada, yada. We throw him in the car, he brought some stuff with us, and we're transporting down the road, and we're like 10 minutes from the hospital, and I'm dealing with his 2 kids. His kids aren't hurt bad, but we're dealing with them, and he was talking, and he said something, he goes, oh no. I said, what? And my back turned, and he goes, I probably shouldn't have this, huh? And I turned around, and he had a 45 caliber handgun in his hand, and I was like, where'd that come from? He was like, my bag, I actually totally forgot I had it. And I was like, all right, well, put it away. Like, you didn't have to take it out. You could have, like, hey, yo, I got a gun in my backpack, right? You don't have to, like, wave it around like something with a shot. But now it's like, okay, well, it's really easy. Why don't you put it back in your bag, right? We're going to zip your bag up. That bag's going to go in the front seat with my partner. It's not going to be back here. When we get to the hospital, you can't take the backpack in. We're going to let security know they're going to come take care of that. Security was awesome. They came out, they took the gun, they locked it up for him. When he got discharged with his kids, they took the gun with him, right? Like those, you know, in an EMT class, everyone freaks out, right? Oh my God, there's a gun, it's unsafe. There's guns in lots of your scenes, right? We're going to talk about more of that on Saturday. But be aware of that. We'll talk about whether or not you're allowed to search patients for weapons, and we'll kind of give you some tools for that. Ensure your safety, calm patient, perform a thorough assessment. Really doubtful. I kind of disagree with that. Most of these patients, you don't need a thorough assessment. If it's a suicide attempt and you're dealing with a medical or traumatic condition, then sure, go ahead and do a thorough assessment. Other than that, go ahead and just kind of work through this like a normal call. If you need to restrain your patient, go ahead and do so. Just be really aware that be really careful with your documentation, right? Why did you restrain them? How did you restrain them? Was it witnessed by anybody? That way, when the lawsuit comes back that you assaulted them, restraint is an unlawful act in most circumstances, right? So be really prepared to document your way through why did you do it. Because there was probably a good reason. You probably just weren't like, oh, I'm bored, time to restrain them. Right? It was probably leading up to something. They had threats against my life, against their life, against my partner's life. Or what usually happens is we miss all of those threats. I'm going to kill you. I'm going to kill your partner. You're like, that's not nice. Let's not say things like that. Like, you're hurting my feelings. And they start fighting you, and you're like, oh man, I wish I had restrained them 30 seconds ago and not waited until we start losing the battle. We kind of talked about that. We talked through this piece. Let's talk about reasonable force. Did I put the reasonable force video in this one? No, okay, it's in the one on Saturday. So reasonable force. This is the force necessary to keep the patient from injuring you, right? Now, what's interesting is when EMS was told we could use reasonable force, we kind of took this a little bit excessive, right? Our thought is, well, if you come at me and grab a hold of me, that means I have every right to rear back and punch you in the face. Okay, time out. The key word in here is not the word force. The key word in this whole statement is reasonable. Now, guy hauls off and punches you in the face. Most everyone's like, well, I'm just going to punch him back. Well, if he hauls off and punches you in the face and starts running away, that doesn't mean like, wait a second, eye for an eye, go run, catch him, and pummel the hell out of him. It means if he's now removing himself from the circumstances, that means you have to be able to go, okay, you got one, right? Come back here and see what happens the second time, right? Those are the things to think about. If they go hands on you, go hands on them. They attack you with lethal force, guess what? You can defend yourself up to a reasonable level, which means, let's say you had a pocket knife. Guy pulled a pocket knife and stabbed you in a fight with you. Could you stab him? What do you think? If you're still fighting him? Sure. Now, he stabs you and runs away. Don't go chase him down. Hold him down and start, poking him in the legs and, 19 gauge needles or whatever. Be aware of that, right? Those are the things to think about. We already kind of got around this, which was that, does your system allow you to restrain without police or medical control? I really don't want to work for a system that while I'm getting my ass kicked, I have to call medical direction and ask if I can restrain my patient. That doesn't sound like a very fun procedure. It probably sounds like, hey, doc, he was fighting us, we got to restrain him. Is that okay with you? Right? You should involve law enforcement if you can, but if you can't, then you're going to have to kind of protect yourself. That's the big thing we're going to talk about scene safety on Saturday is I'm a big fan of the saying, everyone goes home, right? And when I go to work, the one person I care that comes home, my wife and my kids, is myself. Now, my second priority is you, right? Then my third priority, in my opinion, that goes way down the list is my patient. And even farther down is bystanders. Make sense? The hell with those guys in the water out trapped with their cameras. So, anybody ever heard of this excited delirium? Anybody know what this is? It's been in the news a lot over a couple of years. What are we talking about? What's the outcome of most excited delirium cases? Anybody know? What's the outcome? What do we usually hear about this? What happens to the patient? They died, right? Now, what the story always reads, law enforcement tases man to death, right? That's every single one of them. Every single one of these cases, that's how it reads. Law enforcement tases man to death. Or law enforcement misuses chokehold and patient dies, right? So what's the presentation most common with these patients? How do these people present initially? Combative. Really combative or just kind of combative? Like extremely agitated and combative. Okay? How else do they usually present? Is there a drug usually on board? Yes. Right? Upper. Usually it's an upper, right? Almost, I should say it's always an upper. Right? PCP, methamphetamine, something along those lines. Bath salt, something like that. Not the stuff you put in your bath when you're like stressed out, but the drug. Okay? Not the same thing. Don't try it. Okay? What about this piece right here? If they're hypothermic, or hyperthermic, sorry, how do they usually present? Naked. Right? That's the big red flags, right? Super agitated, naked man fighting everybody. Okay? really, really distinctive presentation. They're pretty easy to spot, right? Now what happens is law enforcement gets called because they're agitated. Law enforcement arrives and attempts de-escalation. Nothing they're gonna do is gonna de-escalate this circuit. They can't talk this person down because mentally they're not even aware of what's even going on, okay? So at some point, law enforcement starts the fight, right? And I don't mean that in a bad way. They have to go hands-on and they gotta subdue this guy or this gal, right? So they get their hands on, and it takes 1, 2, 3, 4, 5, 6 police officers. And as they're saying, you know, put your hands behind your back, he's not listening, he's not listening. So what do? Tase, baton strikes, knee strikes, it's not called a chokehold anymore, it's called a lateral neck restraint, stuff along those lines, and they're doing these trying to make this patient stop. Now, what happens is, as they're containing them, and they're fighting against that containment, it's just upping their metabolism, and upping their body temperature, upping their heart rate, and dumping all these chemicals into their cardiovascular system, and eventually their heart goes, I can't do this, and goes to beat them and they die. And all of a sudden, that person who literally has spent the last X number of minutes trying to kill these 6 police officers stops moving, right? Now, law enforcement doesn't have the same switch that we have, which was, he's not moving, check a pulse. Theirs is, time out. He spent the last 10 minutes trying to kill me. I'll bet you he's trying to trick us. So let's get him handcuffed, let's lay him face down, let's leave him there. Let's call for medics, let's let them do their job. So we roll in 10, 15 minutes later, and guess what? They're dead. Right? We can't do anything about it. Well, they started teaching law enforcement people, hey, when this happens, right, first off, you can hog tie them. We can't tell you you can't handcuff their arms and their legs and then tie them together. What we can tell you is stop putting them face down, right? They can't frickin' breathe. So handcuff them, right? Notice in the video I showed you, they shoot him, they roll him over, they handcuff him, and immediately what position did he go in? On his side. The recovery position. It's just modified because you're in handcuffs, right? It's the handcuffed recovery position. Okay? Then what we told him is, hey, when he stops moving and stops breathing, you don't actually have to wait for us to check a pulse and start CPR. If he doesn't have a pulse, unhandcuff him and start CPR. Because he's not tricking you. Okay? He doesn't have a pulse. He's not controlling that, trust me. Okay? So those are the things we started teaching them, and it's working on treating this excited delirium issue, right? We're not restraining patients. What do you have in your toolbox, or what do you guys think of? What are your tricks in the trade when it comes to restraining people? What's that? Tape. I like tape. What else? Cravats are really nice because they're soft. They feel like bracelets. What else? Anybody ever taken a restraint class? Your agency teach you how to restrain people? Mine neither. Right? So what's funny is you go on your first call where you have to restrain someone, and you're like, oh, hell, I guess we're just going to wing this. Right? Usually it's a more experienced provider who kind of takes over. Right? I always love that first fight you're in. It's always like the new guy's got a hold of a wrist. Right? And everyone else is doing really good, holds it, and the new guy's like, because they don't know what they're doing, right? No one ever taught them what to do, right? So ask the question, hey, if we got to restrain someone, what are our thoughts here? Do we have soft restraints? Do we have hard restraints? Are we going to use cravats? If law enforcement's there, you can handcuff them, but can you transport the handcuffs? It's kind of a gray area, right? In Spokane County, usually the law enforcement guy rides with us or follows right behind us. God forbid you wreck that ambulance and you leave that guy handcuffed to a stretcher because you can't get him undone because you don't have a handcuff key. That's not going to really look good when you have to stand in court and be like, I left him because I couldn't get him unattached from our ambulance. Okay? Restraining a patient, one EMT talks and tries to calm the patient. Right? I guess that person has the bad job. Requires 4 people, 1 on each limb. Restrain all limbs with approved limb restraints in the supine position. Your patients belong supine initially. And then after the restraint, what position do they belong in? Recovery, if you can get them there. If they're restrained to a stretcher, we usually don't have the ability to put them in recovery. What position? Yeah, semi-Fowlers, right? Sit them up, right? Don't leave them laying flat, okay? No more scoop sandwiches, right? No more backboard sandwiches. You know what I'm talking about? A couple, you're like, oh, those are good old days, right? Scoop stretcher, put them inside, put a backboard on top of it, and cravat the two of them together. It's like a little shark cage. You lay them on a stretcher and transport them to the hospital. Supposedly, it's now frowned upon. I think we should bring it back. If the EMS providers were meaner, they'd stop calling us. We'd lower the numbers, right? Anybody in the agency have spit hoods? AMR does. Deer Park has them, right? Now, the nice thing is, it's nice to them, right? Because they can see out of it. I'm a bigger fan of the one you can't see out of, right? They can spit all they want. It's just to protect you. Yeah, non-rebreathers work really good. If they won't stay on because they're moving their head too much, duct tape secures those suckers really well, right? Not all hospitals are prepared to treat behavioral emergencies, so kind of be aware of that. Most hospitals are capable of it, at least initially, maybe not long-term. Choose correct facility based on your capabilities and local protocols. On the consent side of things, be really, really careful about patients who are not consenting to being restrained to a stretcher. So make sure that you document that thoroughly, right? You don't want to open a whole door for lawsuits and things along those lines when it comes to you, right? Why did you restrain them? How did you restrain them? What did you use? Did you provide any warnings before? Like, listen, if you keep getting verbally abusive and saying things like, I'm going to kill you, I'm going to have to restrain you to the stretcher. I told my patient that 2 or 3 times, and then he came at me, and I was scared for my life. So I grabbed him, I forcefully put him to the ground, I got on top of him, and my partner could help me. We restrained his arms and his legs, and tied him to our stretcher. Right? It should hold up in court. Everything that led up to it, make sure you document how you did it, why you did it, and so on. On the sexual misconduct side, really be aware that you probably should have same-gendered providers attending to the patient to just lower any chance of opening that door again for those allegations or those lawsuits. We are hearing, every once in a while we hear a case out of GEMS or EMS1 or one of those magazines about, you know, a provider gets accused of sexual harassment or rape or something while patient was restrained to stretcher. You really should have a third-party witness at all times to make sure you lower the chances of this becoming an issue for you. It's not a road you want to travel down and have to deal with issues. Questions on that?
You talk too fast.
Too fast.
Yeah. Go, talk for 32 more minutes.